All right, so looking at our final lesson today in Special Pops, we are going to be looking at two major populations, clients going through like cancer remission and chronic lung disease. So obviously, you guys know there's a lot of different types of cancers out there. We are spending our time mostly just looking at them in general because like exercise is not going to really even be affected by cancer like as a condition, but exercise will be super affected by cancer treatments. And so really like if we've got a client who's in remission, coming back from cancer, if they've gone through like chemotherapy, radiation or whatever, right, these things are definitely going to affect how they perform in a gym setting because a lot of that stuff is very, it's quite harmful to the body, which is kind of weird to say considering it's like a medical treatment, but it's an example of the medicine being so intense that it just kind of wrecks certain parts of the body. And so really our job is to sort of help someone get back to where they were like before this treatment and stuff. So by definition, when we say cancer, because there are so many different types of it, we're just going to say any of the various types of, we call it a malignant neoplasms that invade surrounding tissues and metastasize to several sites. So we are sort of talking about where a group of like rogue cells, oh God, I'm gonna sneeze. Every time AC kicks on. Any of the various types of malignant neoplasms that are metastasizing, it's a group of like rogue cells, right? So I actually gave this stuff, and I actually gave this explanation yesterday when I was talking to my friends. But talking about like, let's use skin cancer as an example. It's one of the most common types of cancers out there, and when you think about like getting sunburn, right? And it's kind of the same thing that happens every time, you're exposed to like a lot of UV radiation, which we're always exposed to UV radiation whenever we go outside, but we get exposed to an excessive amount of UV radiation. And then what ends up happening is our skin cells, because of all that radiation, it modifies them, right? So it basically messes up their DNA. So when you look at like any cell you've got, right, you've got the overall outer wall and then all the little like organelles inside of it, including the nucleus. And the nucleus is where you contain your DNA, and it tells your cells how to grow and do what they do. But the way radiation works and the way that like any like free radical molecule sort of works is it's like a molecule that has like a missing electron in it, right? Or like it's a molecule that's very reactive. That's what we call we call radiation. We call it like reactive molecules. And so like a reactive molecule is going to look to maybe bind with something else or steal something else's electrons. And when it steals those electrons, that molecule is like nice, and that free radical is like nice and happy now. But the atoms making up the other material, well, now it's missing electrons, so it can't really function properly. And that's sort of what happens in your, if that happens in your nucleus, well, your DNA can't copy properly. So then it makes like a sort of a derpy copy, and then you have two derpy cells, and then then you have four, and then you have eight, and they start to sort of grow. Now, normally your body will come along and be like, oh no, we've got some compromised cells that are not shaped or functioning the way that they're supposed to, and hopefully your body will like repair that tissue damage and stabilize that cell, but it doesn't always happen, and unfortunately, if it starts to grow and then it grows to a point where it can sort of metastasize and start taking over other tissues, that tissue can no longer function properly because you have a group of non-functioning cells that aren't really working. And that's sort of what cancer is, and you can understand like why cancer is so hard to treat and why it's so hard for us to find a cure for. We've got a lot of different types of cells in our body, right? We got blood cells, skin cells, bone cells, like so many different types. And so with that, so many different types. And then also like it's anything that modifies your DNA, that's a lot of things. Usually it can be like free radicals, like diet can affect your status, excessive UV radiation, like I said, or excessive radiation, from other things, we start to see it's like, man, there's a lot of different types of cancer, like lots and lots of different types, and lots of different causes. And so that is just a really bad formula for us being able to like cure something, like even COVID-19, at the end of the day, it's just a virus, as long as they can figure out how that critter is sort of acting and responding and spreading and doing this and doing that, what's in its body and how it's shaped, we can kind of figure out how to kill the darn thing, but yeah, obviously it does take like a certain amount of effort still, but like, that this is one of the reasons why cancer is so hard to sort of cure. Although that being said, because it is a group of human cells, we can give it intense amounts of radiation actually, or chemotherapy and things like that. And basically we are taking sort of a very intense response. What's the term I'm looking for? Not blasted earth, scorched earth. We're taking sort of a scorched earth approach where it's like we're trying to keep the cancer from spreading, so a lot of times it's just like, well, just wipe everything out in that area, and that includes our normal functioning cells, which is why which is what we're going to sort of see. So another really good way to sort of describe it, and this is what I'll usually say whenever I'm trying to be pretty simplistic, but it's a group of non-functional and aggressive cells that keep our tissues from working. And this was the second leading cause of death in the U.S. It will be again. Obviously, COVID is actually bumped itself up there, and sort of moved all of our statistics around. It maybe it's still second actually. Leading. Okay, still second place, and then COVID. Okay, COVID's actually pretty far below that. There's all the other ones that got bumped. But yeah, so we definitely see, a lot of people struggling with the various different types of cancers. And like I said, our job is going to be helping people who have sort of recovered from that or who might be going through treatment for that. Our job is to improve their quality of life. We're not going to have a major positive impact on the disease, but we will absolutely have a major positive impact on the client, and if we can improve their quality of life and make things easier for them while they're going through this, then I would say that's a job well done. So 44% probability if you're a male, 38% probability of a female at some point throughout your lifespan. That's a pretty darn high statistic, considering that it's somewhat preventable, so this is just another reason why it's so important for us to sort of know how to like treat these things, catch these things early, communicate with your doctor and stuff. But let's go ahead and talk about the considerations. Like, how do we, what are our adjustments to make? How do we sort of work with this? Well, any of the biggest consideration we're going to be dealing with by far is going to be excessive fatigue, or like with diminished, that is going to result in like very much like diminished activity. The treatment for something like this is absolutely exhausting. And so clients who are going through cancer treatment, that radiation, that chemotherapy, the drugs associated with it are just so very hard on the body, because again, it's like, I actually had a client doctor who used this analogy for me, which is so funny because I love analogies, and that's why I remember it forever. And he was like, basically cancer treatment is like watching a zombie movie where, zombies are taking over like a city and the government's like, nuke the whole thing, like yeah, there's plenty of innocence there, but we got to stop this thing from spreading. And they just take that approach of just like wipe it all out, and that's kind of what we see in this treatment, right? Radiation, chemotherapy, they absolutely wreck your cardiorespiratory system particularly, but really your entire body. We see a decrease in muscle mass. We see a decrease in immune function. So like your client's muscle mass decreases, which is going to result in them feeling very lethargic and tired and worn out. It's going to decrease their immune function. They're going to feel like they catch colds more easily and they get sick more easily. Just regular chronic fatigue, needing naps consistently, like all of these things that sort of result in just like a chronic, much more sedentary lifestyle, which in its own way is dangerous and a bummer, right? We know about our cardiorespiratory system taking a hit there. We know about our regular muscular system taking a hit there, and our skeletal system. We talked about sedentary, over the last like week and a half, right? And so all these things are definitely like, side effects that are rough, right? So if those are our considerations, well, then we need to look at the positive impact that we have on exercise, or with exercise, the positive impact exercise has, and see if we can engage in that in order to sort of stem some of these negative responses. So one of the big responses that right off the bat is just an increased retention of lean muscle mass, right? Again, if you gotta think of like, at the end of the day, it's not like here's the interesting thing about like how chemo and how like radiation therapy actually works. I've said that it causes like muscle wasting, and it does. It's not like you walk into a chamber, get blasted with radiation or something, and then all of a sudden your muscle mass has disappeared. Like it's not like it deleted it by magic special rays. It's not like a reverse Captain America chamber, from the Avengers. It's not that. Like what happens is you get blasted with so much radiation that we are hoping that the cancer cells are going to go, oh, I am just, I'm going to destroy myself because I'm compromised. We're hoping to trigger that reaction in the cells, which is why sometimes chemo and things like that don't work very well. Sometimes they work really well. It kind of depends on the person and what the response was. But what happens when that occurs is the immune system comes along and is like, oh, you need to be destroyed. Great, we got you, right? And it kind of comes along and like clears all that out. Now, a lot of times what happens is other functioning cells, the same thing happens at the same time, right? And so we see that happen in lean muscle mass in particular, right? We see our lean muscle tissue get modified, and so it self-destructs rather than just the cancer cells themselves. And so we see a major decrease in lean mass. It takes time, like we see this disappear slow because it's your immune system that's sort of cleaning this all out. Like actually, it's not too dissimilar. Somebody asked me about this a long time ago, and I was like, no, there's no way that works. But then like I ended up doing more research on it, and something that I am absolutely like fascinated by, even though it like kind of bums me out, is this idea of like cryolipolysis. So the freeze your fat, the cryo slimming, this stuff here where you see like, these big machines that people go, and people were asking me, it's like, does that stuff work? And I wanted to say no, because, and at first I did, I was like, there's no way something like that works. But again, I actually don't know much about skin. It's an area that I'm it doesn't have to do with moving the kinetic chain. It doesn't do, like I don't spend too much time remembering my skin biology. And so I was like, there's no way that like a thing that freezes you could kill your fat by getting through the skin without damaging your skin. So at first I was like, there's no way. But then I looked more into it because somebody was bugging me about it, my roommate. And turns out like your skin's actually way more temperature resistant than your fat cells are. So the way those machines work is they drop the temperature so low that your fat cells get damaged and your skin doesn't. And then the fat cells self-destruct, like we're sort of encouraging in cancer treatment. So what'll happen is like you don't see body fat reduction walking out of the studio. I refuse to call wherever those places are gyms. You'll hear people say that. Spa, I don't know, whatever you want to call, wherever they have those freeze the fat things. You'll see somebody walk out. It's not like they lose any weight walking out of there, but they lose it very quickly over the next couple weeks because their immune system basically cleans out those dead fat cells. And so you basically end up like peeing it out over the next couple weeks, like just like you do with all your viruses and stuff. So that's crazy, right? Like that's what chemotherapy does, but it also causes muscle damage. The freezing your fat thing doesn't. Muscles are also pretty resistant to that damage, but it does absolutely do that with like chemo and radiation and stuff. So other types of tissue. So we see this like fatigue decrease like over the coming weeks, but we do know that exercise can cause like sort of a retention here. And so doctors will absolutely encourage their cancer patients to exercise very, very regularly while they're going through treatment, because remember the way muscle building works, right? We create a little bit of cellular damage through exercise, and the body goes, oh, I need to keep this tissue around, or more likely what it goes, I need more of this tissue, right? Like you go do 10 push-ups, you get exhausted, let's say that's as many as you can do, right? Your body goes, oh man, like all the chest muscles got damaged. All right, and then it gets to work and it repairs it and makes it a little bit more, like a little stronger, a little bit more resistant to damage. And then you're good. And then you go back to the gym and you do 15 push-ups. Your body's like, oh God. And then it builds it back up. And then you come back and you do 20 push-ups. And so, that causes the build. That's how we build lean mass. Well, if you're going through cancer treatment, exercising regularly can help you retain lean mass because your body is deciding like what to get rid of. It's not going to get rid of the things it's using. So when you're using your muscle, it's like, all right, we're going to keep that tissue around, It also improves your aerobic and anaerobic fitness levels. So by maintaining the size of those cells, you're going to be maintaining your anaerobic fitness levels, right? Remember, that's glycolysis, right? We're producing energy in the fluid of the cells. You're going to maintain your ability to do that if you can keep the darn cells around. You keep the cells around, you keep their fluid around, so that helps. And then also it improves our aerobic fitness levels as well. When you exercise, that causes your body to generate more mitochondria, but it also generates more like enzymes. One of the things that we don't spend enough time talking about is like, I'm sure you guys have experienced this yourself. If you've ever gone like on vacation, you're gone for like a week, maybe 2 weeks, week and a half. And you don't get to exercise in that time, right? And then you like go back to like play sports or something. You feel so out of shape after like 1.5, 2 weeks, and it's like, what the hell happened there? Like, like I look the same. I can still jump just as high, and I can sort of push the same weight when I'm in the gym, but I just feel way more out of breath pretty quickly. Like you'll notice in sports in particular. The reason that happens actually is not so much because like you've lost a lot of muscle. Thank goodness that's not what happens. It's not because your brain has forgotten how to do things. That's not really what's happening either. Really what it is the enzymes that help some of the chemical reactions with aerobic and actually anaerobic metabolism, they just kind of die off. They're some of the shortest lived cells in your body. Enzymes really don't last that long. So if you're not continually making new ones, and you're skimping out on your cardio, unfortunately, aerobic metabolism, it feels very rough very quickly. It disappears very quickly. But luckily, you can build it back up pretty much just as quickly. You can get those enzymes back within 1 or 2 weeks of effort, which is really nice to know. But this is one of the reasons why like new clients will actually feel so much like they're getting in shape so quickly. Like they'll be like in the first month, like I feel like I'm in such better shape. And it's like, yeah, you're literally just making like new enzymes that are helping your chemical reactions, helping you output energy more efficiently. Because you're finally like using that, which is always really great. Like people feel really good really quickly that way. So we do know it'll improve both aerobic and anaerobic. It improves mood and self-esteem. Obviously, emotionally, it's just very difficult going through something like cancer. But we know exercise produces like endorphins and things like that. So it can improve like how somebody feels about themselves. It can improve their overall mood, which is great. They'll experience less fatigue. Right, we go back to that aerobic fitness levels, right? With improved aerobic capacity, all of the normal activities of everyday life are just, going to be less fatiguing. So again, like we definitely want to exercise there. Does it make the gym less fatiguing? Yeah, absolutely. But it also, like, probably more importantly, makes life in general less fatiguing. So that's going to be a really, really, really big one there. So we really like exercise training. That's a big deal for us. With like our clients and stuff. So yeah, the effects that exercise is going to have. I mean, obviously these are sort of the responses that we're looking for there. It's going to be very important for us to put the emphasis on like our strength, put the emphasis on endurance. So that is going to be a lot of strength training in particular. Should you be doing a lot of cardio as a cancer survivor or as a cancer patient? Sure, build up that aerobic fitness level. Absolutely, it's going to be helpful. But I would say also like putting plenty of emphasis. You really want to have a pretty good balance between like strength and endurance. Long duration cardio, not really something I would put a lot of emphasis on with a cancer patient. Not that it's not good in general. It's a very legitimate type of athleticism, but it's not what I would do to get my client back to where they were. So their goals should be really to return, to their prior fitness level prior to cancer. So with that, all these different types of tissues sort of getting destroyed by this treatment. Don't forget, guys, that is going to affect their balance as well. So like when they lose muscle, they're also going to lose like proprioception. When they lose neurons, which is another tissue that we didn't really talk about so far, but yes, those are going to get destroyed as well. They're going to lose balance. So getting your clients to return to improve their balance is going to be really helpful. We like a lot of like balance exercises, stabilization type exercises that are in an unstable environment. Those can be great for cancer patients. Bone remodeling, we do want to put enough stress on the skeletal system in order to cause the body to actually repair that skeletal system. So I like relatively high intensity if I can do it with my client. Absolutely. That's going to result in obviously muscle growth, but it's also going to result in bone growth. And then reducing muscle weakness and the muscle wasting effects of cancer treatment is absolutely going to be huge. Making sure that strength training becomes a very regular part of a routine. Again, I told you guys, like, cardio is either your client's least favorite thing or it's their favorite thing. So many people just want to go to the gym and do cardio alone. That's not the approach we want them to take. We really want to have a pretty good balance here with plenty of strength training. So they get a chance to kind of do that as well. So when it comes to the flexibility stuff, static stretching and active stretching is recommended. They can do SMR if there's no complications, but honestly, it's not going to ruin them. It's not that dangerous to foam roll with them, but they bruise much more easily when they're going through cancer treatment. And so foam rolling can actually be pretty rough with that. And we don't want our client to just live life like a banged up banana. That can just be painful and annoying throughout the day, which means they're not going to enjoy working out. They're not going to get all the benefits. So SMR can be fine, but just make sure you encourage your clients hey, if this bruises you, if this is bugging you, we don't need this. We can cut this out, until that becomes less of a problem. So SMR is optional, very much so. If there's no complications, I say do it. But if they bruise very easily, we gotta be careful. Oh, no sweat. I'm sorry to hear that, dude. Did you get him?
but he give me hard time to. Okay,
but
I'm here.
you got him.
Yeah.
Okay, thank God. Yeah, I'm dog sitting for the next 2 weeks, and if one of those dogs ran off on me, yeah, you bet class will be starting late. I'm just glad you made it. By the way, what's up, John? I didn't say hi when you got in. So yeah, glad to have you guys this morning.
Everything's cool.
So yeah, so static and active is probably the most common, but yeah, SMR if they can do it. Cardiorespiratory training, start with stage 1. We do want to start with that endurance first. I know I just got done saying like I wouldn't do like super long duration cardio. What I mean by that is I wouldn't emphasize super long duration cardio. However, on cardio days, yeah, I would focus on getting into the aerobic system so I can build that foundation first. 20 to 30 minutes, or as low as 15, depending on what it is. Strength training wise, I would definitely be focusing on strength. So, generally we sort of put our strengths together and we sort of avoid our weaknesses when we're writing a program for someone, where it's like, hey, I got a bodybuilder. Yeah, I'm only going to do very limited cardio because my job is to build up as much muscle as possible. I got a power lifter, kind of the same thing. If I'm doing cardio with a power lifter, I'm probably focused on sprints because it's high intensity, and power lifters are high intensity. If I've got a marathon runner, I'm not going to do I got a lot of running to train for. I'm not going to do as much strength training. Cancer clients are kind of the opposite. It's like, hey, I want to, in the gym with the strength training, I want to be similar to a bodybuilder. I just want as much muscle as possible. But outside of life, I'm not trying to actually like build a body, and gain a ton of muscle mass. Instead, I'm trying to like keep their endurance as well. I need them to have that cardiorespiratory capability. So probably going to have cardio specific days that are very stage 1 focused, and strength days that are very strength focused, but start with stage 1, and then you can progress to 2 and 3 if they get medical clearance for it. And then guys, we're going to be putting a huge emphasis on core and balance training. Because again, chemotherapy, radiation, all that stuff is really going to affect our muscle mass balance and coordination. So we want to make sure that we get that back as quick as possible. So our modes, treadmill walking, stationary cycling, rowing machine, low impact step aerobics, all of it's good when it comes to cardio. You're like, it's not on here, but what about jump roping? Sure, yeah, absolutely. What about elliptical machine? Yeah, we don't hate that. Go for it. Anything that's going to help them build up and get their wind back. Frequency, we're going to see about 3 to 5 days per week. I love a good Monday through Friday schedule, and then with the weekends off for recovery. Intensity, 50 to 70% heart rate reserve. So remember, we are taking into account our client's resting heart rate when we use the heart rate reserve method. So use that Carvenin formula. So heart rate max, 220 minus their age, minus their heart rate rest, whatever their heart rate is at resting, which will probably be several beats higher once they start going through this treatment, times the desired intensity. So let's say 65 to 75%. And then add that resting heart rate back on at the end. That's the heart rate reserve method. I guess I said 65 to 75%. I'd say somewhere between 50 and 70%, right? Duration, 15 to 30 minutes per session. I know that's pretty short, but again, with that fatigue, that's going to feel like an eternity at first. Once we start to kind of build up that endurance, that core strength, and that muscle strength, then we can sort of extend the sessions. But a lot of times, like, this is about as much as a lot of people are going to be able to handle. For the physical assessments, it's all pretty much the same stuff. Push, pull, overhead squat. You can do a single leg squat if they can handle it, but chances are even just a single leg balance would be enough, just to see how their balance is doing. Balance is going to be affected. Balance and coordination are going to be affected for sure. Flexibility, like I said, SMR if it's tolerated, but generally static and active stretches are recommended. And then when it comes to your resistance training, now here's something that I sort of disagree with. I get it. But we're gonna see 1 to 3 sets of 10 to 15 repetitions. Sorry, not the, I emphasize the 10 to 15 repetitions. I don't love the high 15 reps here. I would definitely start with that if it's a beginning client as well. You know, like let's say it's a client who maybe didn't have like a lot of strength training experience. And then, they're starting to get into it and, they're in remission and coming back from that. Doctor told them to strength train. Yeah. Oh, absolutely. Somebody like that, I'm starting at 15 reps, beginning client for sure. But if I got a client that I'm trying to get their strength back, I'm going to stay on the lower end. I'm going to stay right in the middle of glycolysis if I can. 10 seconds at a 202 tempo. 1, 2, 1, 2. That's 40 seconds per set. That's perfect, right in the middle of glycolysis. So this is probably where I'm going to emphasize things. What I would probably do is say, every set, I'd be like, Julio, I'm going to have you do 3 sets between 10 and 12. If you can't get to 10, the weight's too heavy. If you can get all the way to 12 through all of your sets consistently, the weight's too light. Let's go up with the weight, and then next time we're going to aim for 10 again. So if you're doing, let's say, a lateral raise, right, and you get 12, and then you do set number 2, you get 12, you do set number 2, you get 12 again. Great, let's go up by 5 pounds. Next session, it's like, maybe you get 12 again. Wow, great, even going up a weight. And then it's like 10 and 10, it's like, great, this is right where I want you. That's called double progression, by the way. It's where you give a rep range, and every time they hit the top end of the range, you go up next session. 2 to 3 days per week. So for me, I think honestly what would work really well on something like this is just a stabilization routine of between 10 and 12 reps, or maybe 12 to 15 if you want to do that, Monday, Wednesday, and Friday, with like dedicated cardio sessions on Tuesdays and Thursdays. I think you do that, you're going to be balancing your cardio and your strength training really, really well. If they can't quite handle that, great. Monday, Wednesday, Friday cardio, Tuesday, Thursday strength training. I think that would work really well as well. A little less emphasis on the strength, a little bit more emphasis on the endurance. Maybe that's where you start. And then as they get a little bit stronger, we shift it, we flip more to the strength side of things. It's going to depend on where you're headed. With special considerations, avoid the heavy lifting in the initial stages of training. So like I said, first month, yeah, maybe we do 12 to 15, but my emphasis is going to be getting them to a place of like 10 reps if I can. And you may need to only start with 5 minutes of exercise in the very beginning, and then work your way from there. One of the reasons why we put cancer with chronic lung disease today is because, they could be really, really fatigued guys, like completely wiped out, exhausted, and so it may start with just like 5 minutes on their feet, and they're just going to need rest after that. I had a client who friggin' had to go through cancer treatment twice, beat it both times, but it was like this woman, she would get in really good, she was super like tough lady, and she'd work her butt off and get in really good shape. And then she went, and then sure enough, she ended up going through cancer therapy, and lost a lot of that. And she would go, she never, like, I didn't train her one-on-one. She was a client that I used to train in these small group training classes that I would do. So it was like anywhere from 4 to 6 people. And so she would always come to those classes, and she would lead those classes. I mean, like, she was at the top pushing everybody, which was awesome. I was in charge of the class, but she was like the, top client. And then cancer treatment completely tanked her endurance and stuff. And then, she beat it the first time, kept coming back to those classes. And it was great to see, like, she'd be completely out of breath, completely exhausted. And then like slowly she built that up back over time, then went through the therapy again, endurance completely tanked. and then built it back up again afterwards. And actually, by that point, I stopped working with her. I actually moved out. I moved away. But I see her on Facebook now, and I see everything she posts, all of her fitness stuff. You know, she's killing it, and she's back to being like super strong, super fast. You know, she's crushing it. So it may need to start with 5 minutes. You know, she would get completely exhausted and just always had a chair available for her during those sessions. She would not like just do 5 minutes and then like give up. What she would do is like these small group classes were an hour long, and so she would do maybe 5 minutes at a time and take maybe a 5-10 minute break if she needed it, and then like step back in just wherever we were. So she would do like little 5 minute bursts while she was doing that. That may be what your sessions look like, you know, and that's fine. That's where it starts, and we build it up from there. Any questions on that, guys? Any questions on working with clients going through remission or therapy?
So just staying away from what's it called? The stretching with the foam roller?
Oh, SMR.
SMR.
Self-myofascial release. Yeah. Watch it because of the bruising. Watch it because of the bruising. That can be, you know, and it's like, what's wrong? You know, what's so bad about bruising? Honestly, not really that much, you know, but it hurts. So you want your clients to enjoy their sessions, you know, that's why that recommendation is there. John, do you have a question? You feeling good? Saw you flash for a second.
No question. Just feeling good.
Okay. I'm always trying to like, I like, it's funny on my end over here. It's like watching, you know, I'm always like looking for a box to light up. Cool. Yeah, no, of course not. All right, let's take a look at chronic lung disease. So chronic lung disease, you know, there's a lot of different respiratory diseases out there, including going through cancer treatment, you know. But these are sort of like the special treatments that we're going to see here. There are sort of two categories of lung disease that work very differently. They honestly act the same. Like, I mean, sorry, I shouldn't say the disease. Your clients kind of act the same in response, but there is sort of like two different versions of what's happening here. So lung disease in general is going to be any and all conditions that decrease your ability to bring in oxygen, right? But there is sort of a different way that this manifests. There's restrictive lung disease, which is like an elephant sitting on your chest. You know, you're just going to not be able to freaking open your lungs, you know? This is where your fibrous lung tissue has a decreased ability to expand. So cystic fibrosis, which is like a disease where you get like scar tissue buildup in your lungs, keeps your lungs from being able to open, keeps your lungs from being able to expand properly. So your lungs, the empty sacs that draw in oxygen, are restricted. You know, they can't open properly. And then the other one is obstructive lung disease. This is what you probably think of when you think of like smoking, right? Or hopefully this is what you think of when you think of smoking. And this is where you have altered airflow due to like obstruction in the lungs from, you know, mucus production and things like that. So obstructive lung disease can be things like asthma, emphysema is a good example, chronic bronchitis, right? So what we'll often see, sort of the most common, you know, version that we just sort of like blanket category call obstructive lung disease is COPD. You guys probably heard that term before. It's chronic obstructive pulmonary disorder, chronic obstructive lung disease, right? And it's where a client experienced decreased airflow because of mucus or other substances blocking the airways. So that's the thing about like smoking, right? When you think about like somebody bringing in like a cigarette and then exhaling, right? It looks like all of the like chemicals go in and then like all the smoke comes out, right? Like it's like it goes in and then it comes out. Not all of it does. Do you guys remember when we were talking about the first law of thermodynamics? We talked about how like anything in a closed system, it can't be created or destroyed. You know, it's always remains constant. The way they figured that out wasn't meant to be like a dig on cigarettes or anything. But like one of the first experiments that ever like proved that was a scientist very simply took a cigarette, put it on a scale, lit it, and then put a glass jar over it. And the cigarette burnt up, and the weight of the scale did not change. Like the cigarette was gone. There's a little bit of ash left, but how freaking light is ash, you know? So the cigarette's gone. Why does the scale say it's the same weight? Because all the stuff is still there. It's just microscopic and you can't see it. So when you see somebody like exhale when they're smoking, it looks like it's all leaving the whole, but really the reality is tons of it are getting trapped in this wet, sticky environment that is your lungs, right? So we look at like COPD. If I just Google that, what we're going to see are examples of like airways that are covered in mucus, right? So we're seeing right here, this is a normal healthy airway that can be nice and open. And this is well, that's actually, we're seeing a lot of inflammation. Inflammation will cause this as well. I do want a good picture of like mucus. Yeah. Trying to get the right image here. I mean, you can really see what I'm talking about. You can see tons of it. Oh, that'll work. It's getting to where we're seeing the airways all messed up as well. I want to get to that in a second, but there we go. You can see gunk. It's literally gunk building up on these tubes. So that's not great, right? And this is why, you know, we see like, you know, you see that classic, I'm sure we all remember those commercials from the 90s, where you see like a healthy lung versus a smoker's lung. There's a really great joke by Norm Macdonald that was really funny. And he was like, they always try to scare you out of smoking. Like, oh, look, this is a smoker's lung. And you're like, oh, it's gross and disgusting. And then they show you like a normal, healthy lung. And you're like, no, it's gross and disgusting. He's like, I don't understand why that works on people. But you know, I'm sure you guys have seen, you know, pictures of smokers' lungs before, right? And we see like, you know, this is what's kind of funny. I mean, here's a normal healthy lung, you know, after all the red blood cells have been drained from it doesn't look very red anymore. And there's like a smoker's one, and it's literally just like particles of stuff. You're just seeing like, I mean, we've all got ash on our hands before, you know, at a campfire or something like that. You know, that's covering the pores in your skin and stuff, and you can wash it off later because it's external. But if this is internal, you've got no way of cleaning that stuff out of there. And so like it just builds up and starts covering up the tissues, right? And when that happens, we see like we see decreased capacity here. I mean, look at if we try to run oxygen through like a smoker's lung versus running oxygen into like a normal healthy lung, right? Oh, that one's not. I need the video version of this apparently. Oh my God. Yeah, I mean, obviously that's more, but let me get a video of this. Smoker versus normal. There we go.
Take a look at these two sets of lungs. This set is pink and healthy.
They represent the lungs of a healthy person, but this set doesn't look so great. They represent the lungs of someone who has smoked a pack of cigarettes, that's 20 cigarettes, every day for 20 years. Let's take a closer look at what's happening in the healthy lungs. They're being inflated with air, just like when we breathe. As they fill up with air, both lungs expand like they should and push oxygen into your bloodstream. We need oxygen for our body to work. When we breathe, air passes through our nose or mouth into our trachea or windpipe. In the trachea, air passes cilia. Those are tiny hairs that keep dirt and mucus out of the lungs. From the trachea, air passes into two large tubes. Each tube splits off into many smaller tubes. At the end of these smaller tubes is a cluster of tiny air sacs. There are over 600 million air sacs in our lungs. Imagine how small they must be. Each air sac is covered in small blood vessels that take the blood directly to your heart. The oxygenated blood goes directly to your heart, and your heart pumps it to all the cells in your body. Now, back to the smoker's lungs. These represent the lungs of someone who smoked for 20 years. These lungs are a blackish brown color because of the tar that comes from each cigarette. Tar is a sticky black substance that is created when some chemicals burn and melt together. The tar created by burning tobacco is similar to the tar that is used on roads. Tar in your lungs may lead to lung problems that can make it hard to breathe. Even though vaping doesn't force tar into your lungs, it does cause your lungs to get inflamed and clogged with blood, pus, and other fluids. The chemicals in cigarettes also cause lung cancer. If you look here, lung cancers have started to form. They start in the cells that line the surface of the lungs, like this white area. The lower portion of this lung doesn't inflate. That is what lung diseases like COPD and emphysema look like. People with these diseases find it hard to breathe, and they struggle with even the smallest, easiest activities like walking. Which set of lungs would you like working for you?
All right. So we definitely, this is an airway problem, right? Like, it's not going to be able to expand properly. The airways are filled. And then at the end of the day, the other big issue here is that, like, we got to remember how our blood vessels work, right? If we look at like the alveoli, your alveoli are these little like popcorn sacs at the end of your airways, right? So like all of those tubes that we're seeing here, right? They branch and they branch, they get smaller and smaller, and then they're covered in these little sacs that are covered in blood vessels, right? Those blood vessels need to be exposed to oxygen. So if this is filled with this sticky black substance, right, oxygen's not going to be able to get through. And so then what ends up happening is you end up with something like emphysema. Emphysema is a different type of lung disease where, here's a normal healthy alveoli with these little walls here. But if you cover up some of these walls, well, now the pressure increases like crazy. And so what can happen is that pressure goes through a smaller tube because the other ones aren't there anymore. And it breaks the walls, decreasing your surface area. So now you're left with one big chamber, which is very different. This wall here and there and there and there, right? That increases surface area. More oxygen is able to actually be transmitted. Here, that's way less surface area, because none of these walls exist anymore. So emphysema is also a very, frustrating disease that sort of comes along with things. So a lot of problems with this. And then we go back to like why lung cancer is so common. Well, you got to remember like the chemicals from vaping, cigarettes, those chemicals are like, I'm pro chemical. Water is a chemical, when molecules bind together, they form chemicals. Chemicals are fine. It's the ones that interact with human stuff that I have a problem with, and unfortunately, cigarette chemicals are some of those, right? So, what ends up happening is they're very reactive molecules. And so they start stripping electrons from tissues surrounding them. That tissue is you. We talk, and that is what causes like cancer. If DNA gets changed, it makes an imperfect copy of itself. And so that is why these diseases are so dangerous, is because they really are quite deadly when you cannot, move that oxygen the way you're supposed to. So a lot of times, frequent things that are sort of associated with cardiovascular disease is frequently associated with lung disease. Remember, your heart and lungs work very much together. Your lungs extract the oxygen from the environment, and your cardiovascular system pumps blood cells around to deliver that oxygen. But if those blood cells are not getting any oxygen and, they can't deliver it to tissues, well, now those tissues actually decrease in their ability to utilize oxygen because they're not getting it very often. If that happens in your heart gets weaker. If it happens in your muscles get weaker, right? They're just not able to output energy very effectively. So a lot of times lung disease is very much associated with cardiovascular disease. You become more sedentary because you just can't pump out as much energy. And then the heart, gets very damaged. So with restrictive lung disease or obstructive, really, individuals will often experience a more sedentary lifestyle, which results in that chronic heart disease that we talked about. Now, one of the things that we're going to notice with clients who have any version of lung disease, they're going to be experiencing earlier fatigue from what we call dyspnea. Dys coming from the word dysfunctional. Actually, I don't know what the nia is. The thing that sits there to sit. Huh. I don't know. Oh no, actually it doesn't come from dysfunctional. That's crazy. Oh no, it does. It comes from bad. Oh, it comes from dyspnea, which means breathing. Okay. That was too short of a word for me to be able to break down. Anyway, dyspnea is shortness of breath, dysfunctional breathing. So dyspnea, this shortness of breath feeling, your client is like just never able to catch their breath. It's because they can't, expand their lungs properly. They can't, get things to function properly. So they experience this particularly during upper body exercise. So clients who do have lung disease, you got to be careful, like when you are doing too many upper body exercises in a row, because it actually causes problems for them. They'll get more and more and more out of breath. Think about doing like push-ups, right? You are locking all of this in. It makes it harder for you to be able to expand your diaphragm and breathe. So we actually got to be careful there and watch that for that shortness of breath whenever we're doing upper body stuff. They may use supplemental oxygen. I'm sure we all know somebody who's on an oxygen tank. And then they may experience muscle wasting, very similar to our clients with who are going through like chemotherapy and radiation, right? So that can lead in what we call sarcopenia. So John, this is exactly what you were asking about the other night, right? Sarcopenia is a condition in which we see a decrease in muscle fiber size, right? So when we decrease that muscle fiber size, your muscle becomes worse at being able to pump out energy, right? So sarcopenia, right? Actually, that works. Is sort of what we're seeing here, right? So we're seeing like a young, healthy muscle here versus like an older, maybe like atrophied muscle over here. And there's just a decrease in the number of cells. You see, they're all like much smaller there, right? And so like the size of them is substantially sort of like shrunk here, right? In what we're seeing. And so that results in the whole muscle looking much smaller. We would call that sort of like atrophy, So there we go. Inactivity, right? We see smaller cells. Inactivity plus aging, we see less and smaller cells, okay? So sarcopenia, definitely something we want our clients to avoid, but it comes along with cancer and it comes along with chronic lung disease. If you've got lung disease, you're not going to move. When you don't move, you don't keep your muscle mass, So like I said, negative effects that we're going to see here. We're going to see a decreased ability to exchange gases. If there's mucus or, other material, pus or tar or whatever covering your cells, they're not going to be able to transmit oxygen. Air can't get through there. We do see decreased ventilation as well. It becomes much more, we saw in the video, like the lung wasn't able to expand properly. That's decreased ventilation. Remember the difference, right? Respiration is gas. is like oxygen molecules actually moving from one place to another. That's respirating. Ventilating is bringing gas from one place to another. Both of these get worse with lung disease. We see low levels of exercise. Obviously, somebody's just not going to want to move much. And then we see shortness of breath. We see these shallow breathing patterns where they're just, breathing very quickly. They feel out of breath, even if they aren't doing like a particularly high amount of exercise. But we do know that exercise does have some positive effects here, right? We see an improved functional capacity, right? They develop a little bit of tolerance. One of the things that sucks about shortness of breath is it feels scary. It's a panicky feeling. But if you exercise regularly, that uncomfortable feeling goes away, right? So we call that an improved functional capacity. It's like they can function better as just sort of a byproduct of, learning to deal with that uncomfortable nature of exercise. We see a decreased shortness of breath symptoms. Literally, they're able to expand their lungs better. Psychologically and physiologically, we see some benefits here. They're going to be psychologically much more positive. I mean, the other day I was like working out. I was trying to get through. I was jump roping. I think I was talking about this the other day on Friday. I was short on time, and so I was jump roping. And I'm not like the best jump roper. I'm not terrible at it. I've done it enough over the years of exercising that I can get a pretty good rhythm. But I'm still to this day really bad at lateral movements. So when you're jumping, like, high knees, butt kicks, single legs jumps, the ollie shuffle, like all the stuff is fine. I can even do pretty well on like the crossovers and stuff. But I suck at lateral jumping with the rhythm of the rope. I don't know what it is, but when I do like a lateral bellhop or something, I always get my foot tangled up. And you're out of breath, you're making adrenaline, you're making cortisol, and like I get so freaking frustrated sometimes. And there's just like, that's the psychological nature. You're creating stress hormones. Now, luckily, you feel great afterwards. You do get that psychological benefit afterwards, where you feel much more positive, you feel much more, you feel much better psychologically and physiologically there. But that's sort of what comes along with exercising. Exercise is stress. So if you can expose yourself to that stress, and then your body's going to learn sort of how to deal with it much better. It also increases your internal locus of control, which is really fun. Remember, internal locus of control is the belief that like you are in control, not external forces. We talked about this very briefly during our child psychology or our youth sort of psychology class. But this internal locus, right? This belief that it's like your actions matter and are what sort of shape things. That's what we see, rather than an external locus of control, right? How many people do you guys know, just think in your brain right now, how many people do you know that are the people that stuff happens to? What I mean by that is like, that person who's like always late, their life is, they're just really unlucky. They're like, oh, all this stuff always happens to me. Like, I've tried to leave on time, but then like this happened and I tried to do this and I did this. And it's like, oh, I'm so sorry. They're always apologizing for being late, but they're also always like being like something happened to them rather than being like, hey, I'm sorry I'm late. I didn't leave the house on time. That's an external locus, like the belief that like all this unlucky bad juju is happening to them, versus an internal locus, which is like, look, I'm in control of my life and I screwed up. Like there's sort of a difference there, right? Or like the person who's like, I'm never gonna get ahead in life because like, I don't have any opportunities, versus the person who's like, well, I'm going to make opportunities, right? That's an internal versus external. External is like the world is controlling you. Internal is like you are controlling your world, super fun conversation. We've got more time to talk about it in later classes where it comes up. But this is actually the belief that you're in control of your life, right? Rather than this disease controlling your life. And that's one of the big benefits of exercise in general, is that like you are at the helm, which is awesome. Makes people feel great. So I love a good internal locus rather than external. Exercise considerations. One of the interesting ones is that we are going to go back to that peripheral heart action style of training. Remember how we talked about like peripheral heart action for our clients with hypertension? We go upper body, lower body, upper body, lower body. That's great for clients with lung disease. That seems really weird because it's like, well, is it going to make their lung disease better? Not really. It doesn't have any benefits to the condition, unfortunately. But it does feel much better to the client because you are giving their upper body time to rest, which will allow them to breathe easier. It is harder to breathe when you are doing shoulder presses. It is harder to breathe when you're doing rows. You are just moving your collarbone, you're moving your rib cage, you're moving all these things around, which make it hard to breathe. This is already a person who has a hard time breathing. So if you do like a bunch of upper body stuff in a row, they're going to get further and further and further out of breath. So by going upper, lower, we can manage that out of breath feeling. So very different reason here, right? So elliptical trainers are good, treadmill walking, steppers or stationary cycling, anything like a rowing machine, probably not so much. That's going to kind of collapse in and make it hard for them to breathe. So we're going to avoid those. Frequency, we're going to see 3 to 5 days per week. Intensity, you'll notice we're going to base this on peak work capacity. So it's going to be based on how they feel. Basically tell them it's like, hey, I want you to work to build up your endurance anywhere from 40 to 60% of your maximum effort when it comes to your breath, right? So we're not going super, super, super high here. Duration, we're going to work our way up to 20 to 45 minutes, but it may start just like our cancer patients, 5-10 minutes at a time, it just depends on like how out of breath they actually are, but we're going to see a pretty short duration here at the floor. And then the ceiling is probably only going to be 45 minutes for most clients. Not that you can't get them higher than that, but it takes a lot of effort to build that lung capacity back. Movement assessments, totally normal. Push, pull, overhead squat, single leg squat, totally normal stuff. Static and active stretching is fine. Self-myofascial release can be fine, but Simon, we were talking about like avoiding it for bruising earlier. With a client with lung disease, we avoid it because generally people are putting themselves, like you're holding yourself in a position that makes it hard to breathe. So be careful with foam rolling because that can also cause that dyspnea, that out of breath feeling that they get from collapsing things down. For resistance training, you will notice because they do not have a lot of endurance, we are dropping it down to our lowest training volume that we've seen. 1 set, 8 to 15 repetitions, 2 to 3 days per week. That might be all that you can start with. Then yes, we can get into 2-3 sets, things like that. But a single set system here is actually probably going to make a lot of sense at the beginning stages of things. 20 to 45 minutes, like I said. Special considerations, watch out for that upper body exercise. It can cause that shortness of breath, and just give them plenty of rest in between sets, guys. These clients are going to recover super, super, super slowly between sets. So peripheral heart action means you're probably going to organize it and do like 1 set of an upper body exercise, 1 set of a lower body exercise, and then just sort of keep moving through different various body parts. It's not a ton of work in the beginning. It seems like it's a very short workout, and it seems that way because it is. So not too surprising there. Whoop, that's my osteoporosis client. Whoops, hold on. I was like, I remember Jude. Jude was from Friday. All right. Oh, I remember this person as well. This was actually, I remember the student who made this. This is actually based on a legitimately like real friend of one of our ex-students. This is our client. Her name is Tatiana, and she is in remission for breast cancer. And she was like a major like athlete, big time athlete before she like got sick. And was like also like super, super fit and a big pole dancer. That was like her big thing for like fitness and stuff, which is something that she wants to get back into. Big tennis player as well, and worked over in Long Beach, apparently. I never met this person, by the way. But like this person like literally worked as a rocket scientist. So like they like worked down in Long Beach at SpaceX, which is freaking awesome. However, generally a pretty sedentary job. So favorite form of fitness is doing like all that cool like pull stuff, and then playing tennis for cardio. But they're often sitting at a desk for like 4 to 6 hours a day. So, you know, the goal is to increase the energy throughout the day, get the upper body strength for the dancing, get their cardio endurance back for tennis. They're 37 years old, 145 pounds, 5'8", very normal statistics there, you know, not seeing any obesity or anything like that. During the overhead squat, we notice that the arms fall forward and there's a little bit of an anterior pelvic tilt, as well as like the shoulders elevating. And then during the pushing and pulling assessment, we also see a low back arch. So we're just seeing like a lot of anterior tilt, a lot of tightness in those hip flexors. Makes sense. They're sitting 4 to 6 hours per day. A lot of tightness in that low back, you know, trying to keep the body upright there. And then we try to get them through like a 1 mile Rockport walk test. But even like that 1 mile is just too much. Couldn't necessarily walk a full mile. Completely exhausted, totally out of breath, couldn't get there. Again, just going through like that remission from like, you know, cancer treatment, it's going to be really, really tough on that. So not a lot of wind in this client right now. So like I said, we did the overhead squat, we did the push pull, Rockport, even if we couldn't get there. We tried to do the max push-up test because that one's going to be really relevant for the upper body strength for like isometric, like, you know, calisthenic pole dancing. However, was not able to quite get through that just yet. We don't see that up here. And then we also did a dead hang assessment. Now that one's not in your textbook, but it is literally how long they can hang from like a pull-up bar. And we're just going to track that over time. So those are really two really cool assessments that we can track in the beginning, and we can track our progress of our client. If we see like the push-up numbers going up, great, that means their upper body's getting stronger. If they can hang for longer, great, their grip strength and things like that are getting stronger. Again, that's going to be very helpful for hanging on to that pole or bar or whatever you want to call it. So for cardio training, we want to work our way up to 30 minutes on the treadmill 3 days a week. We're probably not there in the beginning stages, but that's all right. We're going to try to get there. 50 to 70% heart rate reserve. So that is based on her resting heart rate rather than feelings of shortness of breath. Flexibility training, we are going to SMR in this case. Lats, pec minor, we're going to use the lacrosse ball to get on that one. The upper traps, we're going to use the lacrosse ball on that. Hip flexors for that anterior pelvic tilt, TFL for that anterior. Remember, your tensor fascial latae is a hip flexor. So both of those are related to that anterior pelvic tilt. We're going to work on that. Strength training, we want to go 2 days per week, starting 1 to 3 sets, somewhere between 10 and 15 reps each time, at a slow tempo. So that's at 4-2-1 tempo. We are very much putting the emphasis on stabilization exercises here, trying to get that balance, trying to get that core strength back. And then I like the idea of doing like a TRX suspension trainer. I'm sure you guys have seen those, you know, that suspension trainer with the straps is going to be really good. Again, this person, you know, their favorite form of fitness is a body weight style of training. So it makes sense to me to work on body weight styles of training. It's also very good for their core strength. It's very good for their balance, right? Calisthenics, those are body weight exercises, right? That's going to be great. And then we're going to focus on movements in the frontal plane for their lower body. So a lot of like lateral movements. You know, resistance band, clamshells, leg raises, lateral movements there, right? Lateral lunges, anything which is going to be really good for tennis, which we want to get back to eventually. Probably not going to have the endurance for that for quite some time, but it is one of the hobbies, right? That's their favorite form of cardio. So special considerations, we are going to avoid the super heavy lifting. We're not trying to collapse the lungs down and make it hard to breathe. We want to have a chair available in case they get exhausted and they need to sit the entire time. So we're just going to make sure that we have that available as a backup option. And that's our client, right? Yeah, I remember my student Deborah. She helped make this. This is like legitimately like her friend. This is the last day of class, and she like called her friend and asked her. She was like, "Hey," and she like had a soap note, and she like built them all. It was awesome. It was like one of my favorite examples. And that's about it, guys. Any questions, y'all? How y'all feeling?
Yes, I have a question actually. And the cardiovascular, you say is like 30 minutes, three days a week.
2 to 3, yeah.
Okay, but on my experience, when I just start, even the maximum I was able to do was like 10 minutes, and I was dying.
Oh, I believe.
In that case, I mean, we can start like with 30 minutes. We can start lower, checking the resistance of the client.
Oh, for sure. I think it does say, hold on, let me go back to it. I don't think it says start with 30 minutes. I think it's like work. I think it's like, it says 15 to 30.
Oh, okay. Got it.
Cancer, yeah. Coming back from like chemo and stuff, yeah, 15 to 30. But look at the special considerations. We may need to start with 5 minutes and then progress from there.
Okay, got it.
Absolutely. Yeah, you'll see that in your book too. So yeah, no, I believe it, man, right? Like that stuff, you missed a little bit of it in the beginning, but like the chemo, the radiation, it not only does it kill like muscle mass, it also kills like the chemistry, kills the enzymes. So like if you don't have any of those like enzymes there that allow you to, remember enzymes, right? They kick off our chemical reactions, right? And like metabolizing, creating energy, right, is a it's a chemical reaction. So if you like kill that chemical reaction, like you can't produce energy, and so you just feel completely wiped, completely exhausted. So yeah, we might start with 5, but we're trying to get to 15, eventually 15, eventually we're trying to get to 30, and then the table ends there at 30. But I'd say, yeah, work your way to 60 eventually. It's going to take a long time to get there, but like, definitely worth the trip.
Okay, thank you.
Yeah, of course. Any other questions, guys?
Nope.
No, thank you.
All righty, cool. Guys, I get to see you tomorrow in the flesh. So yeah, I'll go ahead and wrap up the recording here.